Good morning. I promise I won't take more than 10 minutes, but if I could just ask for the lights to be dimmed, please. I just have a 1-minute AV to show you. India will require as much as an additional 1.75 million beds by 2025. So as I wrote this speech last week, I did so with a certain amount of trepidation, because the reality that we're facing today in this country is by far removed from an ideal platform in which we can launch a program to achieve that target with only 11 years to go. The harsh reality today is that remote villages are still lacking chemist shops, let alone a clinic. And although the government has set up more than 22,000 primary healthcare centers, most of them are just hollow structures, because doctors, radiologists, pathologists and other trained personnel are very hard to find. Good doctors and other skilled medical workers prefer to work in larger cities, where they have access to, more importantly, better remuneration and better facilities. That's not to mention the ongoing problems we have in the villages of access to an adequate electrical supply without frequent interruptions that causes havoc with all our medical equipment. In stark contrast, India, as the world's largest emerging market exporter of pharmaceutical products, and India has incubated some of the most globally prominent generic pharmaceutical companies. On the other hand, India has one of the worst records regarding immunization of children against diphtheria, whooping cough, tetanus, and we also have one of the world's worst records of life expectancy at birth, pregnant women receiving prenatal care, births attended by skilled health staff, and the number of hospital beds and doctors per head. So why and how does such a confluence of contradiction exist? This is even more astonishing when you take into account that health systems in many other countries, including the advanced economies, are prevalent with doctors and medical staff of Indian origin. One of the reasons, I think, is that public spending on healthcare in India is one of the lowest in the world. It's only 1.2% of GDP. The percentage of overall public spending on health is just 29% in India versus 84% in the UK, 83% in Japan, 77% in France and Germany, and 53% in the USA. If we compare ourselves to our other major emerging market peers, the trend is very much the same. 75% in Thailand, 62% in Russia, 54% in China, and 47% in Brazil. Therefore, it's blatantly clear that we have to address the divide. We have to increase our public spending and aim to make healthcare accessible in the most far-flung corners of this country. This can only be achieved by a combination of different methods and approaches. As Dr. Pachauri also mentioned, the tax incentives introduced by the Finance Ministry for the healthcare sector must be taken advantage of. And a realization that public-private partnerships, these initiatives must be concluded, resulting in many more new hospitals across the country. Along with new hospitals, We need to build new medical colleges and training centers so we can disseminate our knowledge, skill, and information. We should also look at building more healthcare cities, targeting medical tourism to a greater degree. And when I talk about medical cities, I mean medical cities with 1,500 to 2,000 hospital beds. And technology must be embraced to a much greater degree than at present. The proliferation, I needed coffee this morning, the proliferation of mobile phones and 3G across India opens up the possibility for us for remote treatment in villages and diagnosis of patients using their mobile phones. With the number of cell phone users increasing by up to 20 million per month, this opens up the possibility for us for remote disease monitoring as well as a medium to disseminate health awareness messages and pertinent medical communications. As one of the world's leading IT nations, we have to tap the raw talent that we have and use it to benefit us ourselves. And innovation can't just be about developing new technology products. It must be about new business models for making technology affordable and accessible to more people, and more importantly, keeping it simple. An example I'd like to give you is GE Healthcare's research and development engineers in India had to come up with low-cost alternatives as a means or a contrast to the company's high-end ECG machines. So to get their end result, the GE engineers didn't pare down their existing ECG machines. Instead, they went back to the drawing board and based on customer feedback, they developed a machine called the Mac-I. It's an affordable, it's portable ECG machine with basic features and more importantly, a long battery life so we can battle the electricity disruptions in the villages at $500 US. That's a cost of 1/20th the cost of ECG machines in the West. So needless to say, this machine is now seeing great sales uptake here and hopefully will be placed in more of the remoter clinics that we have in the country. Another example of simple innovation and desire to succeed is illustrated by a doctor in South India. I don't know if any of you are aware, but there's a doctor by the name of Dr. Satya Jagannathan, was posted at a rural hospital where the statistics of infant mortality, as I touched on before, run extremely high. As India has we have a very high infant mortality rate, so a high number of babies die during their first 4 weeks of life. The cost of Western incubators was very high. And we also have the problem in that the staff that we require to run these machines, again, don't want to come and work in rural India. So what did Dr. Jagannathan do in their particular hospital? They developed a minimalist incubator from a wooden table, a plexiglass top, and a 100-watt light bulb. That incubator costs only 5,000 rupees to build, and when it was implemented at the hospital, it cut infant mortality rate down by half. Dr. Jagannathan is now working with the Levinson Foundation, which is a US-based organization, to fine-tune and scale the incubator so that can reach more rural hospitals across India. On another vein, as I touched on before, one of the scourges that we face to a greater extent in India is diabetes. And we have Dr. Mohan, who is a globally renowned diabetes expert in Madras. And he's only too aware of these problems. And he has implemented a telemedicine clinic, which is run in a van and travels to the remotest villages in Tamil Nadu, where technicians travel and they transmit retinal scans and diagnostics tests back to Dr. Mohan and his team from their vans. Dr. Mohan and other doctors can see and communicate in real time with their patients. But hesitant to go again for expensive technology via the communication vendors, Dr. Mohan partnered with the ISRO, which is the Indian Space Research Organization, where he used free satellite communications from his telemedicine vans, where neither mobile or wireless signal exists. So these are just some small examples on how simple, back-to-basics approach can help make healthcare affordable and accessible to so many more in our country. What do we need to do as NRIs, and how can we contribute? Simple, by having the will, the commitment, and determination to make that difference. The year was 1963, and on a chilly spring morning in Chandigarh, a woman lay dying, cradled in the arms of her eldest son, as her life gently ebbed away due to an excruciating pain in her chest. "Our country is in dire need of hospitals," she whispered. "Promise me you will build one." The woman's name was Leelavati, my husband's grandmother, and the eldest son that she whispered to was named Vijay, my late father-in-law. Shri Vijay Mehta set about making his mother's wish a reality. That meant him moving from his home in Belgium to live in India, where he supervised the building of the Leelavati Hospital, Mumbai. Brick by brick, oversaw the purchase of each and every piece of medical equipment, interviewed every single doctor associated with the hospital, and stood by proudly as the hospital opened its doors to the public for the very first time. It's that same spirit that we need to nurture as NRIs. Most of us have access to funding, be it in the form of personal wealth or connectivity to financial institutions. We also have access to the technology and the ability to think out of the box, having spent a great deal of time abroad. We know how things should function. So, to set about making a difference, I'm confident that if we put our minds to it, and a few of us in this room today can get together, we all can make a difference and help improve the future of healthcare in India. Thank you.